Good afternoon. In this second video, we are going to start by the treatment of renal failure. We said last time, the last symptom we discussed, or the last disorder we discussed, was anuria, where the patient is completely unable to form urine because both kidneys stop functioning. And this is exactly the definition of renal failure. Renal failure is when both kidneys stop functioning and the patient becomes totally unable to get rid of the toxic materials that are accumulating inside the body. So if we don't interfere, if medical doctors do not interfere, then the patient would suffer from accumulation of toxins inside the body, improper cell functioning, and death. One of the major treatments for renal failure is dialysis, and dialysis is using a machine called the dialysis machine in order to replace the failing kidneys. We keep both kidneys inside the human body, and we connect the blood vessels of the patient to a filtering machine. So we have two types of dialysis. The one that is most famous is hemodialysis, and actually not only the most famous, but also the most efficient, and another one called peritoneal dialysis in certain conditions when it is contraindicated to use peritoneal dialysis, or it is difficult to use hemodialysis, we use peritoneal dialysis. In hemodialysis, what happens is that we shunt the patient's blood outside the human body. We take the patient's blood in tubes outside the human body, and then this blood passes through an artificial membrane, and that artificial membrane separates the blood of the patient, which you can see above. This is the blood of the patient that needs to be filtered from a fluid that will help in the process of filtration and purification of blood, which is called the dialysis. And the patient's blood and the dialysate are separated by an artificial membrane. This dialysate fluid has an adjusted concentration of every ion in order to be efficient in removal of the toxic products from the blood, and at the same time adding what is missing in the patient's blood. Because sometimes in renal failure, not only does the patient have elevated levels of urea and ammonia, for example, but they also might have a diminution or a drop or a decrease in certain substances like calcium, for example, in which case you have to help the patient restore the original level. So, for example, if the patient has, it's a simple process, a simple diffusion process. For example, if in the blood of the patient you have a high level of urea and in the dialysate you have no urea, then urea will diffuse from the patient's blood to the dialysate, and the patient will get rid of the surplus urea. Of course, that process is done at first once a week, and then twice a week, and then maybe 3 times a week, and then every day. And therefore, it is very crippling to the patient. So when the patients find themselves forced to go to the hospital or to the dialysis unit every day, they start thinking about something else, an alternative that is more permanent, like, for example, transplantation of a kidney. that has, of course, its own problems and restrictions, the simplest of them being finding a suitable donor of a suitable tissue matching in order for the kidney not to be rejected by the immune system of the recipient patient. And then after blood has been purified, having lost toxic substances and gained useful substances, blood returns again to the vein. As you see, the blood arises from a vein and returns to a vein, but here we have something called an AV fistula or an arteriovenous fistula. It is a connection that is done, of course, usually the artery and the vein are not connected to each other, but here through a surgical operation, the renal surgeon does this fistula or this communication between the artery and the vein. Why? Because in order for blood to be moved outside the human body at an adequate pressure that allows it to circulate in those vessels outside the human body, then here the pressure should be high. Now, we cannot put this end of the tube or the vessel in the artery because insertion of anything in the artery, in the arterial wall, would be extremely painful and wouldn't be tolerated by the patient. But we can just insert it into a vein. So the tube arises from a vein here and returns to a vein there. Why then are we connecting the artery to the vein? In order for the blood at high pressure in the artery to be communicated to the vein and therefore add pressure to the venous blood to allow it to leave the body under high pressure and therefore to be able to circulate for adequate distances into the tubes. The other type is peritoneal dialysis, and here, as you can see, this is the peritoneal membrane, and this is the space inside the abdomen, which we call peritoneal space, that is between the abdominal organs. And what happens is that we have the machine that contains the fluid, and the fluid is connected to the abdominal cavity, and in a certain way, the fluid is pumped into the peritoneal cavity. The dialysate fluid is pumped into the peritoneal cavity, and instead of diffusion occurring through a partially permeable membrane, as in hemodialysis here, it will occur across the peritoneal membrane. So actually, we pump fluid into the peritoneal cavity and then withdraw that fluid. So we withdraw it after a certain period of time during which toxic materials have diffused out of the body and useful material has been pumped to the body. Now, the symptom after anuria, another important symptom or complaint of the patient is hematuria, and the prefix hema or heme means blood, and this simply means the presence of blood cells in urine. And in order for the medical doctor to facilitate its task, they must ask the patient at first whether this hematuria is a painful hematuria or a painless hematuria, meaning that if the patient comes, of course, the patient doesn't come telling you, I suffer from hematuria or my complaint is hematuria, but he comes telling you that I have seen that my urine contains blood, or I'm complaining of bloody urine. So the second immediate question you would ask the patient is it painful or not? Is it associated with painful micturition, with dysuria, with burning sensation, or not? Furthermore, is it associated with any kind of colicky pain? Because colicky pain that is due to spasm and spasmodic contraction of the ureter, for example, will always be associated or will always indicate a stone most of the time. So if it is a stone in the kidney, as I told you before, for example, a big stone in the renal pelvis, we call it a renal stone. If it is a stone in the ureter, it will be a ureteric stone. Of course, ureteric stones cause more colicky pain than renal stones because, as we said previously in the classroom, that these renal stones that are lodged in the renal pelvis move very little, and therefore they show very little symptoms, and that's why they can stay in their place and enlarge without the patient being aware of them. So this is the first cause of painful hematuria. The second cause or type of hematuria is painless hematuria. But before leaving painful hematuria, we have another cause for painful hematuria, which is bilharziasis. And bilharziasis then would be letter C. I'm sorry, this is not letter A. And bilharzia is a disease that is endemic in Egypt, and it is transferred to the person via polluted water when the water contains a worm-like structure called cercaria, which is one of the stages of the life cycle of the bilharzia worm. And the cercaria circulate or navigate or swim in fresh water, and they have glands here. And through these glands, they can perforate the skin of the person who swims in the polluted water, and then they leave their tails outside and penetrate with their heads and cause severe itching. And then they continue their life cycle in the human body and finally give the adult worm. The cercaria is the larval stage. The cercaria is a larval stage. It's a young worm. It's not the adult worm that can reproduce and lay eggs. And the adult worms, male and female, reproduce inside the blood vessels of the human body that are very close to the liver, and they start laying eggs. The female lays eggs, but when the female lays eggs, it lays these eggs in the wall of the urinary bladder, and these eggs have spines, and the spines are terminal spines. That's why they cause bleeding or bloody urine or hematuria, bloody urine or hematuria. So the infective stage is the cercaria. It's not the egg, but the egg is the cause of hematuria. This is very important because many of you are confused when it comes to the infective stage. We say that the cercaria is the infective stage. Why? Because it is the stage that is capable of penetrating the skin and transferring the infection from the polluted water to the inside of the human body. Whereas the cause of the bloody urine is not the cercaria, but it is the spine of the eggs that penetrates the wall of the urinary bladder. And then we have another type of hematuria when the patient comes telling you that there is blood in urine, but this blood is painless, meaning that it is not associated with any kind of pain, especially colicky pain. Sometimes the patient suffers from burning micturition with hematuria, but this is not the main type of pain we're talking about. The main type of pain we are asking about, and that helps you differentiate between the different causes of hematuria, is essentially the colicky pain, the pain in the loin, in the back, at the position of the kidneys. When the patient doesn't suffer from any pain, however, he suffers from, or despite having suffered for a certain period of time of hematuria, then we think of one of two things. Number one, glomerulonephritis. Of course, the name is difficult, but if you split it, then Here you will have the glomerulus, and here you will have the nephron, and here you have itis, which is inflammation in the nephron and in the blood vessels of the nephron or the glomerulus. And usually it is an autoimmune disease. And by autoimmune disease, auto means self. This means that your immune system is attacking you. Your immune system is attacking your own kidneys, and in particular, your own nephrons and glomeruli or glomerular capillaries. And this results in severe inflammation, and it will result in enlargement of the pores of the glomerulus. So if this is the loop of glomerular capillaries or the spherical structure of the glomerulus, then the pores will not be as small as the normal ones, but they will be larger. And since they become larger, therefore anything that was previously hindered or prevented from being filtered because of its big size, like essentially the red blood corpuscles, now it will be filtered, which is very unusual. It is unusual for the red blood corpuscles to be filtered because they are larger than the size of the pores. But if the pores are enlarged because of autoimmunity, then they will appear in urine. Not only the RBCs, but also another item or another type of particles that were prevented, which are the proteins. And on top of the plasma proteins that will be allowed now and unusually to be filtered, we have albumin. So albumin, why specifically albumin? Because albumin is one of the smallest proteins. So proteins essentially are bigger than the size of the pores, but when the pores are diseased because of an autoimmune disease, when they get inflamed, they widen. And when they widen or become wider, they will allow particles that were previously prevented, like albumin, to pass in the filtrate. So normally we don't see RBCs and albumin in urine, but in glomerulonephritis, we do see albumin and RBCs in urine. Usually it's interesting to know that glomerulonephritis usually occurs 15 days after an attack of sore throat or tonsillitis, because some bacteria, if you don't take the full course of the antibiotic and if it is recurrent, then some molecules of the bacterium will stay in your body, will attach themselves to the kidney tissues, and they will be identified by your tissues will be identified as foreign, although they are your tissues, just because of one simple reason, that they are attached to some bacterial molecules. The second cause of painless hematuria is a systemic bleeding disorder. And a systemic bleeding disorder means a disorder that affects the ability of the blood to clot or to become semi-solid and to stop bleeding. And this affects the whole body. Usually this occurs because of two main reasons. You know that inside the blood, we don't only have red blood corpuscles to carry oxygen to the tissues and white blood cells for immunity, but we also have fragments of cells that are called platelets. And although they are very small, and although they are not true cells, but they are small fragments of cells, yet they are very important for blood clotting. So if the platelet count usually is 150 to 350,000, meaning that you have to put by 10 to the power 3 per cubic cc of blood, per cubic centimeter of blood. So if your platelet count is less than 150, then you will have bleeding. Whenever you have a minor injury or a minor skin abrasion or wound, any very simple procedure or trauma will result in excessive bleeding. The second, and there are people, of course, who are born with diminished platelet count. But there are other reasons for a systemic bleeding or bleeding all over the body, which is the intake of anticoagulant drugs, anti-clotting drugs, or thinning drugs. Usually, we don't want our blood neither to bleed excessively nor to clot excessively. We need our blood to clot whenever clotting is needed, and to be thin and liquid whenever this is needed. But it happens that some people suffer from a clot, for example, in the brain or in the heart, leading to a heart attack or to a brain stroke. And after having passed through this difficult situation or disease, medical doctors advise them to take anticoagulant drugs, drugs that prevent coagulation of blood, like, for example, drugs that prevent platelets, antiplatelet drugs, or even aspirin. These drugs will prevent clotting of blood and will prevent, of course, recurrence of the disease. So if a certain patient takes these drugs excessively or in larger doses, then he would suffer of bleeding instead of suffering of clotting at the beginning of the disease. Then we have hematuria, again, painless hematuria, again. This is what? There is a third group of hematuria that starts painless and then finishes or ends up by being painful. So we had the painless hematuria that is all the time painless throughout the course of the disease. We have the painful hematuria that is painful from the very beginning. And then we have a third group of hematuria, or a third type of hematuria, or diseases that cause hematuria that start with painless hematuria in their early stages and then turn out to be painful, like, for example, cancer bladder. So malignancy or malignant tumors in the bladder or cancer bladder, for example, if this is the urinary bladder, so you might have an outgrowth like this that consists of malignant cells. And usually malignant cells divide very rapidly to form a huge mass of cells, and they start eroding or eating up the blood vessels. And themselves, they are very vascular. And that's why there might be, because malignant tumors are capable of creating their own blood vessels to nourish themselves and to support their very high rate of growth. So it starts painless at the beginning when the growth, the malignant growth is still small, but as the malignant growth increases in size, it starts compressing nerves and being painful. So the symptoms would be, of course, hematuria or bloody urine, together with dysuria or painful micturition. Pelvic pain, of course, because the urinary bladder is at the very bottom of the abdomen. It lies actually in the pelvis, which is the lowermost part of the human body and the lowermost part of the abdomen, and sometimes backache. But in order for cancer bladder to cause backache, it has to be the tumor, or the tumor here, I mean by tumor, the growth, the malignant tumor has to spread, because you know that malignant tumors are very fast growing. They do not have capsules, they are not encapsulated, and therefore they can invade any tissue around them. So if they invade the vertebrae or the vertebral column or the nerves at the back of the body, they might cause severe pain. And that's why this pain occurs at the end of the disease, when the tumor is big enough to invade other tissues. One of the very interesting and actually not common but important symptoms or disorders is the neurogenic bladder. And when we say neurogenic bladder, we mean a disorder that is characterized by a disturbance in the nerve supply of the bladder, because the urinary bladder, just like the rectum, will send sensory impulses to the brain about its status or how full it is with urine. So there will be a sensory information or sensory impulses that will reach the brain. And at the same time, the brain will send orders to the muscles, to the very thin muscle in the wall of the urinary bladder to contract, and to the sphincter here, which we call the urethral sphincter, to dilate in order for micturition to occur. So when the urinary bladder is full with urine, there is electricity or electric impulses that reaches the brain. Not only this, but you have the feeling that your bladder is full. This is sensory information because it gives you a certain feeling or sensation. And then the brain makes the decision according to the circumstances. And if the circumstances are favorable, then there will be electric impulses that will pass along the motor order, giving order to this thin muscle in the wall of the urinary bladder. If you want to know the name, it's the detrusor muscle to contract, and meanwhile to the sphincter to relax and dilate to allow urine. Sometimes, and mainly due to diabetes, you might find that either the sensory nerve is not working or the motor nerve is not working. If the sensory nerve is not working, so this is called the sensory neurogenic bladder. And in such a case, the patient will not feel the sensation that the urinary bladder is full. So actually, the urinary bladder will continue being filled with urine without warning, without giving information to the brain that it is full, until comes a time when the pressure of urine inside the bladder is more than the ability of the sphincter to close the bladder, so the sphincter yields and urine dribbles outside the body. This is what we call incontinence of urine or leakage. On the other hand, in the motor neurogenic bladder, what happens is the opposite, meaning that sometimes the sensory is okay and the patient feels the desire to micturate, but he cannot do anything about it because his motor nerve is damaged or is not working. And therefore, although the patient feels the desire to micturate, yet he cannot evacuate the bladder. Of course, it is extremely painful because in such a case, in the second type, which is the motor neurogenic bladder, it is extremely painful, and the patient feels that the bladder is full, but he cannot do anything about it until comes a time again when there is overflow, there is incontinence and dribbling. Of course, the best question here to ask the patient in order to differentiate between the patient would come suffering from dribbling of urine or from incontinence of urine. And the best thing to ask the patient about in such a case is to ask him about pain. Do you, sorry, not pain, but the feeling, the desire to micturate. Do you feel that you want to go to the toilet but cannot evacuate your bladder? If yes, then it is a motor neurogenic bladder. But if on the other hand, the patient can evacuate the bladder on purpose, but he doesn't know that the bladder is full, then it is sensory neurogenic bladder. Of course, in case of the sensory neurogenic bladder, it's easier to manage because in such a case, the patient would make the decision voluntarily to go to the toilet and void or evacuate his urinary bladder every hour or every 2 hours in order to avoid incontinence. He doesn't feel the desire to micturate, but he knows how to evacuate the bladder. So it's easy to schedule going to the toilet and evacuating the bladder. But on the other hand, in the motor neurogenic bladder, he cannot do anything about it. And in such a case, we have to insert like a very fine tube in the urethra of the patient, which we call a catheter, in order to help him evacuate the bladder because it would be extremely painful. One of the severest pains and severest colicky pains is the pain of retention of urine, because before leakage and incontinence, there is retention because the patient cannot evacuate the bladder. And here is the neurogenic, here is the explanation. I said you do not have to know the information on the diagram. You just need to know what I said about the presence of a sensory nerve, a motor nerve, a sphincter, how urination occurs, and the difference between a sensory and a motor neurogenic bladder. So you can skip this slide. The last disorder that we are going to discuss is senile enlargement of the prostate. Underneath the urinary bladder, specifically in males, there is a gland that is called the prostate gland. And the prostate gland can be seen in a lateral view in males. The urethra in males is longer than the urethra in females, and it is surrounded by that gland, which is very important to provide nutrition to the sperms and helps formation of the seminal fluid. Unfortunately, the prostate gland at old ages can become enlarged, and when it enlarges, it compresses the urethra, because as you see here, it is present at the base of the urinary bladder or at the neck of the urinary bladder. So it compresses the urethra, and you can imagine what would happen if it compresses the urethra. First of all, because the urethra is compressed, then the process of micturition is not easy. So the old male goes to the toilet and tries evacuating the urine that is present in the bladder, but it is not evacuated completely. So every now and then, he feels the desire to go back to the toilet, and therefore there is frequency of urine. Part of the frequency is due to incomplete evacuation of the urinary bladder. So part of it is due to incomplete evacuation of the urinary bladder, but sometimes the frequency is due to the cystitis or the inflammation of the urinary bladder that occurs in cases of senile enlargement of the prostate. Senile means that occurs in old age. He also suffers from other symptoms of cystitis, like urgency, meaning that every 10 minutes, every 15 minutes, he feels an urgent desire to micturate. So there is frequency, meaning that he goes frequency to the toilet, but not only frequency, but also urgency or precipitancy. Within very short time intervals, he feels an urgent desire to go back to the toilet to evacuate the bladder, but unfortunately, he wouldn't be able to evacuate it completely. There is also hesitancy, because from the very long-standing compression of the urethra. The urinary bladder becomes distended with urine, the muscles become weak, and the patient has difficulty to start the act of micturition. This is what we call hesitancy. And sometimes the stream is forked, meaning that the patient has a double stream of urine. The urine does not leave the urethra as a single stream, but as two streams. So it is bifid, or it is divided into two. And finally, of course, as we said, there is incomplete emptying of urine. This was the last urinary disorder. After this, inshallah, most probably at school, we will be discussing diabetes mellitus and diabetes insipidus, because they result in urinary symptoms. But today, inshallah, this would be the last thing I'll explain, which is this has been the last thing, which is senile enlargement of the prostate. See you next time, inshallah, at school, and you have to watch this video in order to be able to answer the questions on the worksheet that will be sent. Bye.